We can start now.
Yes.
Okay. A very good afternoon, everyone. I'm Dr. Mansi Jain, the co-convener of SIG Endoscopy, and it is my privilege to welcome you all today for this joint webinar between SIG Endoscopy IFS and the Delhi Forum of IFS. So before we begin our academic program, I would like to give you all a slight insight into our SIG. So basically, SIG is a special interest group of IFS, and we have a very dynamic team which is headed and mentored by Dr. Kuldeep Jain, who's the mentor, and the convener is the famous Dr. Parul Kotadwala sir, and Dr. Desh Deepak sir and I are the co-conveners. So our aim is to specially promote the correct and ethical practices of endoscopy in the infertility preparation. And I'm very happy to share that we have been conducting so many academic and research activities. And also, I'm very pleased to share with all of you, we were also awarded the best SIG this year at the Fertivision. Here, I'd also like to share we have a very dynamic and vibrant team of endoscopy members who are constantly in touch with us, and they help us organize and they participate and spread good work, good endoscopy knowledge and work with everyone. So, this is a personal open invitation to each one of you. Whoever shares a passion for endoscopy, please feel free to contact me, and we can work together in collaboration. Without further ado, I would like to hand over the session to our very vibrant MOC for today, Dr. Raksha Sharma. Can I please have a CV, Karan? So I welcome Dr. Raksha. She's the MOC for today. She's a director and senior consultant, CHF Clinics, and she's also the vice president of Kota Obs and Gynae Society. Over to you, Dr. Raksha.
Thank you, dear Mansi. I would like to congratulate all of you, and I am very pleased that you gave me this platform to share it with you all, the highly eminent speakers. I would like to invite Dr. Shweta Gupta, madam, who is the current team leader at present. She is convener of Indian Fertility Society, Delhi Forum. So I welcome you, ma'am. Madam is presently working as director IVF Max Super Specialty Hospital, Delhi, Noida, and she is director SG Clinic, Wave City, Noida. And she has run her fellow represent. Uh, she is having a bit Delhi IFS Forum team leader in 24 to 26. She is SIG IFS endometriosis convener during 24 to 26 and editor of Indian Fertility Society during 22 to 24. So, madam has various things by her name. She has published many publications in various journals, and she is great leader. So I welcome you, Shweta Gupta, madam, for further proceedings.
Thank you, Raksha. Thank you, Mans. So on behalf of Delhi Forum, really welcome you all. And it's a lot of efforts. Actually, thanks to Mansi, I think she's put a lot of efforts and very frequentizing one or the another on a very important and relevant topic. And today's topic is again very relevant, I think, especially for the members of Delhi Forum. Delhi Forum was launched about 6 months back. It was by our founder, Dr. Kuldeep Jain sir, and the current president, Dr. Pankaj Talwar. And we have very enthusiastic team of young consultants. And I'm very happy that, they are all participating in such webinars. And today is on a endoscopy topic. Last month we did on endometriosis, and this month we have this great, I think very practical topics. And thanks to Mansi for selecting very good speakers and relevant topic. When we can use, hysteroscopy, how it can enhance the fertility, what are the, the complications, what are the important things which we as the reproductive medicine consultants should keep in mind. So thank you, Mansi, and the whole SIG team for involving Delhi Forum. And I'm happy to see here Dr. Anurag, Yukti, and the young consultants. They have always been coming every month. We do some activity and they're there along with our other SIG teams. So I'll hand over to the Dr. Raksha so that we can start with the first session. Thank you, everyone.
Thank you, Shweta ma'am. Now, without further ado, let's move ahead for our first topic, that is fertility enhancing surgeries, hysteroscopy surgeries. So, for that, I would like to invite uh, our chairpersons first, who will introduce Minu Agrawal madam. So, I would like to invite our first chairperson, Dr. Kuldeep Jain sir. So, Karanji, can you have the CV of Kuldeep sir? Um, Good evening, sir. Sir is presently laparoscopic surgeon, infertility and IVF consultant, director KJ IVF and Laparoscopy Center at Delhi. He is immediate past president Indian Fertility Society and chairperson of Endometriosis Committee FOXY during 2017 to 2019. Founder secretary and IMM vice president of Indian Fertility Society. He is board member of IFS and has many publications, and he is doing very great and written various chapters on infertility, ultrasound, and in embryology subjects, and has organized various numerous national conferences and workshops on IUI, IVF, and endoscopy. So I welcome Dr. Kuldeep Jain, sir. Next, I would
Thank you.
next I would like to invite our second chairperson, Dr. Shivika Gupta. She has more than 8-year experience and had made significant contributions to the field of reproductive medicine, and presently her focus is on IVF, IUI, ICSI, and female factor infertility. So, and she is presently working as junior consultant at Jammu Center for Human Reproduction. So, I would next like to invite our next chairperson, Dr. Anurag Vashisht. Anurag sir is consultant obstetrician and fertility specialist at ANSH Clinic, Janakpuri, New Delhi. Senior lecturer at School of Embryology and Assisted Reproduction, Gurgaon. An author and co-author of various papers and chapters in national journals and textbook. He is gold medalist and also silver medalist in various presentations at AOGD and AICOG. So I invite you, Dr. Anurag sir. And last, I would like to invite Dr. Yukti Bharadwaj, doctor. She is fellow National Board Reproductive Medicine and presently working in ART and reproductive medicine, current treasurer of Delhi Gynae Forum, Central Delhi, and faculty at ISAR and Yuva ISAR national conferences, had won various awards and prizes. So I welcome you, Yukti. I would like to request Kuldeep sir to please introduce our first speaker.
Thank you. Thank you, Dr. Raksha. It is really a pleasure and very happy to see the growth of Indian Fertility Society, especially various SIGs. They are doing really great work. And I must congratulate Dr. Sweta and Mansi for arranging this very focused meeting. As a mentor of IFS Endoscopy SIG, it is really a great pleasure to welcome you all on this very focused activity. And I wish that a lot of messages will go through this program and will be used by all attendees. As far as the topic of today is concerned and speaker is concerned, we are having an excellent orator uh, who will be speaking on a subject which I still feel about hysteroscopy. It is little underused modality. We need to look at the endometrium whenever we are going for a embryo transfer. And that is the only area, because the implantation is one area where we are lacking. We are having very good embryo quality. We are having very good stimulation protocols. But implantation, there's not much headway. We are still sticking up at the implantation failure. And Hysteroscopy is one intervention which is really very helpful in assessing the receptivity of endometrium. So today we are having Dr. Meenu Agrawal with us. She is a very well-known laparoscopic surgeon. I believe that most of you who are attending this must be aware of her specialization. She is Secretary General of International Society of Gynecological Endoscopy, Joint Treasurer, Maharashtra Chapter, Indian Fertility Society, course director. She's running a lot of training program, 15 publications in international journal. And apart from that, I am having a very long association with Dr. Meenu Agarwal as a colleague, and she is a very lovely person to speak with. So, Dr. Meenu, I really welcome you on this platform, and the stage is yours. The topic she will be speaking on fertility enhancing hysteroscopy, how we can really use it in our day-to-day practice. Dr. Meenu, please.
Uh, Thank you very much, Kuldeep sir. Very nice and heart-touching introduction. And thank you to Dr. Raksha, Dr. Yukti, Dr. Shweta Gupta. And I think Delhi has a lot of these forums and special interest groups, and lot of things are all the time happening. So no wonder. So capital city is buzzing so much. So it's really, really very nice to be with everyone here with Delhi group. And of course, Dr. Pankaj sir and Shweta Mittal, both of them are doing great job for IFS, and I am very happy to be talking on fertility enhancing hysteroscopy. I have tried to keep it very simple this lecture for the upcoming colleagues, budding colleagues, as well as a bit of also some advanced surgical procedures as well. So when we talk about fertility enhancing hysteroscopy, we understand that there are two types that we are looking at. One is a office hysteroscopy and the second is an operative hysteroscopy. Jahan par we already know, okay, she has a fibroid, she has a problem, so we are going to tackle that. In office hysteroscopy, we could be knowing that there is a problem which we can tackle at office hysteroscopy, or it could be see and treat, that we look at these three teeth here and we find that this particular tooth is bad and we go to treat that. So it is also see and treat, and of course if you feel that this problem can be tackled by office hysteroscopy, we can go ahead and do a office hysteroscopy. Now, hysteroscopy surprisingly has a longer history as compared to laparoscopy. So, it has a 200 years of history. Laparoscopy came much later. However, laparoscopy became more and more popular, but hysteroscopy lagged behind. There were a couple of reasons. One is laparoscopy was done not only by gynecologists but also by neurosurgeons, general surgeons, oncosurgeons, everyone. And hysteroscopy got limited only to gynecologists, so it didn't take a step forward. And second was, main problem was they could not distend the cavity. So because uterine cavity is a potential space, and the moment they would enter, there would be blood, mucus, and they couldn't see anything till we got good insufflators, thanks to Hamu and Lindemann, that once we had good insufflator. I remember in 80s, in 90s, and early 90s, we started doing conventional hysteroscopy with a normal 4 mm telescope. We would take the patient to the theater, give anesthesia, and then do a hysteroscopy. However, in conventional hysteroscopy, there was so much to do for so little. Sometimes the cavity would be normal, everything would be fine. So just in and out, but for us, we had problems with the financial thing, and for the Western world, they had problem with the manpower. So we are living in world with constraints. Those constraints can be different for different regions. Then came the era of modern hysteroscopy. Of course, women also want to be slimmer, but definitely scopes became, especially the hysteroscopes, became slimmer and slimmer. And now today we are talking about disposable hysteroscopes, which are only 1 millimeter in diameter, and they are just use and throw. When we look at the anatomy, we know that the nerves are going with the blood vessels to the endometrium. So, when a woman has a bleeding during menstruation, she does not have any pain, right? That means these blood vessels which are there at the endometrium, they are not accompanied with the nerves there. So the superficial layer of the endometrium till the basal layer probably have very few or no nerve endings at all. So it teaches us that if we are going to do small surgeries over here, patient will accept it, she will not get any pain, right? The only pain she will have is when we are crossing the internal os, we are touching the fundus, or we are doing a distension. So these are the three times that the patient has pain: at the time of entering into the internal os, if you increase the pressures, or if we touch the fundus. So these are the things that we have to avoid. So when we look here, uh, so when we look here, how does the hysteroscope should enter inside the uterine cavity? It should not touch the walls of the cervix, walls of the internal os, and that is when you can do an office hysteroscopy without any pain. So here we can see this is the instrument which is going here. Because it is a flexible instrument, we think it has an angle, but inside it is actually going parallel to your hysteroscope. So there is no angulation between the instrument and the hysteroscope. So you cannot don't have a manipulation angle like you have in laparoscopy. So we have to manage hysteroscopic surgeries in a way that we move parallelly, and then we can do the surgeries. So this is how in office hysteroscopy we enter the external os, internal os, we enter into the cavity, do not touch the fundus, look at the right ostia, and then look at the left ostia. So no speculum, no tenaculum, we do a vaginoscopy under vision, no cervical dilatation, no anesthesia, and no analgesia. Preferably in the post-menstrual phase. And of course, as I said, a vaginoscopic approach is what is we are following. Now, vaginoscopic approach, when we are using, that means we don't need a speculum. So this is a meta-analysis in 2020 where on 2,443 patients, and they found that there was lower incidence of vasovagal, better tolerated, short procedure time, and the failure rates were similar. Now, if you look at this particular diagram here, now this is the internal os. Okay. Now, internal os is oval in shape. It is not round in shape. So, if we are using a round scope, it will cause pain. However, the newer hysteroscopes, the shape is oval, and this is a very smart thinking, just like smart cities, that if you use a oval scope for an oval opening, then you will need lesser dilatation and you can enter inside without any problem. Another thing which you should keep in mind, again for my junior colleagues here, now this here is the inflow, okay, and this is the outflow here. So these small apertures here, they are the outflow, and this is the inflow. If now inflow causes a distension of the fundus, and that fluid returns and goes through the outflow channel over here. However, if the sister or your assistant by mistake puts the inflow outflow ulta, then the fluid will come from here, it will go back from here, and you will not find any distension. So that is very, very important to understand. Another thing important to understand is that light, it is a 30-degree scope that we are using, and the light cord is attached on the opposite side of the 30-degree scope. So how is that important for us? So if my light cord is on the right side, I am looking at the left side. If my light cord is on the left side, I am looking on the right side. So I don't need to tilt my scope. I can just move the light source, light, right, left, up and down, and I can scan the whole cavity. So look here. Now suppose I was using a 0-degree scope. I'm sorry. Suppose I was using a 0-degree scope, then what would happen? Once I'm inside, to see the right ostia, I would had to tilt my scope, and then the patient would complain of pain. However, if I'm using a 30-degree scope, that is the idea. The I can just tilt my light source to right side or to the left side and look at both the ostia without causing any pain. So always, again for junior colleagues, your dominant hand should be holding your light cable so that you are moving. Just keep your hysteroscope steady at one place and your camera at one place and move your light source. So by moving the light source, you can look at all the 4 cavities in a very nice way. So what all can we do on a office hysteroscopy, and whether we need to do office hysteroscopy before all IVF patients? Well, there are some studies where they have found abnormal uterine cavity in 30% of women, whether when they are being investigated, evaluated for infertility. However, if I have a young couple where ultrasound, everything is bang normal for the wife, and it is a clear-cut male factor oligoasthenospermia for the gentleman, I would probably skip the hysteroscopy. So one size does not fit all, and we need to make our decisions. Sometimes on hysteroscopy, we may find subtle lesions like diffuse polyposis, strawberry pattern, hypervascularization, mucosal, and there are some studies which have shown that if there is nothing found on hysteroscopy, but the patients who had a hysteroscopy done versus the ones who did not have a hysteroscopy done, the higher pregnancy rates were seen in the patients who had a hysteroscopy. Sometimes on ultrasound, we may find a small polyp, or we may find just a thickened endometrium, and we want to evaluate on hysteroscopy how is the endometrium. If you have a thickened endometrium, just a small trick, you just take an IUI catheter and push little normal saline inside. The moment you push normal saline, if it is a polyp, it will start floating. So you can nicely see the polyp. Then you can put a color Doppler and see that if there is a blood vessel supplying to the polyp. Now, whenever we are doing a hysteroscopy, office hysteroscopy, again, you just see it carefully how I am going in. Now, I will just stop it here. Now, if you see here, this is the opening. Okay, this is the opening. So, always keep the internal os eccentric. If it is in the center, it is not a 0-degree scope. If it is in the center and you go inside, you will be hitting the wall. So you have to go either below or up, depending on whether the uterus is retroverted, anteverted, or it is deviated to one side. But this opening should always be eccentric, and then you can just get inside. You see here how I am going. This is the eccentric opening, and this is how patient, no pain at all. There's a small little tiny polyp sitting there, which was not picked up on ultrasound. However, now with better and better ultrasound machines, maybe it is possible to even pick up very, very tiny polyps on ultrasound. Now, I also have a 5 French side channel through which I can either put a scissors, I can put a monopolar hook, I can put a bipolar hook. Only for monopolar I have to change the thing, or I can put a snare. This is a snare, or I can put a I can use a complete tissue retriever system to resect this polyp. So all possibilities are there. This is just a very simple go at the base and just touch the pedal. Sometimes you find this, all of you all IVF consultants, so you're all doing your own ultrasounds. So you find these bands here. So very, very clearly, they are probably some kind of an intrauterine adhesion. Again, this is a office hysteroscopy. You can see here, I go inside, just place my scissors and just give a small nick and I can cut it off. Here again, I'm sorry. Okay, this is not moving. So here again, I can see an anterior-posterior band which is there, and then I again go with the scissors from the side port, and then I can just go and snip this particular band. Takes just 5 to 10 minutes complete procedure. One more thing, very, very important, keep ergonomics in mind when you are doing your hysteroscopy. Always the surgeon's head and hands should be, you can see between the legs of the patient, because if you're moving on the left side, or if your monitor is on the left side or on the right side, then when you come back home, then you can get a neck pain. Also, it may be difficult ergonomically to operate. So this is how always keep your monitor right in front of you. And small subtle endometrial lesions at the time of hysteroscopy can be taken care of. Now she had a very good, everything was normal on ultrasound. However, the endometrial vascularity was not so good. Endometrium was not growing very well in an FET cycle. So suppose you're doing an FET cycle on day 15, 16, you don't find a good endometrium. What are the possibilities? Maybe the estrogen levels are low. Maybe they are not reaching where they have to reach. So if you do the E2 values, and the E2 is at 300 picogram per ml, but the endometrium is thin, and I think it's a good idea to check it out. This video is not moving. To check it out whether there are any adhesions, subtle adhesions, sometimes on one side of the wall, like see over here, they can be taken care of on hysteroscopy. Or even at the fundus, sometimes there are these adhesions, they can be taken care of by the hysteroscopy. There were times earlier we used to also use this monopolar needle with glycine, which now we are not using very much. This was another case which was again normal on ultrasound, just thick endometrial echoes at the fundus. And when we put in a hysteroscope, what did we find? We found that there was a small septum here, and there were two polyps inside sitting over here. Very unusual. But ultrasound was just showing a thickened endometrium at the fundus, and rest of it was normal. So could we put in a hysteroscope? Otherwise, we would not have gotten a pregnancy for this lady. Some patients again also have very scanty flow. Okay, or you find, now this is, you find adhesions at the level of internal os. What to do if you find adhesions at the level of internal os? Two, three things. One is slightly increase the pressure. Suppose आप 100 पे operate कर रहे हो, make it 120 or 140. Then take a grasper and just push your grasper inside, rotating it left and right, in both the directions. Earlier we used to use scissors, but then Betoki said if you use scissors, there are some chances that you can create a false passage. So it is better to go for a grasper, because it will only go into the adhesion, the thinner space, not create a false passage. And once you have opened it out slightly, again increase the pressures, and then take your scope in the direction of where you have opened, and see here I am already inside the cavity. There is a small polyp sitting over here, and there are some adhesions on the lateral wall of the uterus, and they can be managed as an office procedure without any problem. Sometimes on even this was also again a office hysteroscopy, but see here, it is not a septum, it is a thick band of the adhesion going from anterior to posterior. And see, there are small adhesion bands around the ostia and in the cavity itself, and this can also be managed as an office procedure. Then, of course, small polyps, I'm sorry, I think this slide is repeating. Small polyps also can be managed on hysteroscopy. Whenever we find a fibroid, it is a good idea to do a nice mapping of the fibroid. So this is a 3D mapping. We are very lucky that we have somebody in Pune who does excellent mapping for her. We, for the patient, we put it on the wall, and exactly the number of fibroids, the location of fibroids, it 100% matches with the report. So this is how a good mapping will help. And then we do a good classification whether it is possible to do a hysteroscopic myomectomy for the patient or not. So you do the grading not just by the size, topography, penetration, and also by the extension of the base, and it gets a score and another one for the lateral wall. So this is how 0, 1 and 2. So size less than 2, 2 to 5, more than 5. Where is it located? Low, middle, upper. How much is it inside? Figo 0, Figo 1, Figo 2. And whether it is extension of the base, it has a pedicle, or it is lying flat on the base. So all of them, then you count the score, and if the, so this is how you score it, and if the score is 0 to 4, it is low complexity, 4 to 5, high complexity, 5 to 7, hysteroscopic surgery not indicated. Very important for the junior colleagues that they should evaluate the patient, good imaging, good scoring, decide if required, maybe take an opinion from your seniors, and then go ahead for a hysteroscopy. Hysteroscopy is a wonderful a, a tool that you have in your hand, but if not used properly, you can have a complication, and then you lose your confidence to do further hysteroscopy. So a very beautiful procedure, it goes out of your hand. So very important. Now this particular lady, she's 26-year-old, everything seems normal, but she has a 1 centimeter submucosal fibroid. So what does the evidence tell us? The evidence tell us that whenever we have cavity distorting myomas, we must consider going in for a removal of the fibroid. So the evidence tells us that this patient should go for a myomectomy. Now, what I have realized, whenever I take the patient for a hysteroscopic myomectomy, sorry, some videos are not running. In spite of having done a good imaging for the patient, it is a good idea. Dilate करते हो पूरा resectoscope. Before that, just place an office hysteroscope, छोटे वाला, just scope डाल के, just see that this is possible to do a resectoscopy, and then come out, then do the dilatation, and then place a resectoscope. So it will make your life much easier rather than directly placing the hysteroscope. So whenever we are doing a resection with the hysteroscope, a few things we have to keep in mind. One is, of course, nowadays everybody is aware that bipolar is a better method of energy as compared to monopolar. So use a bipolar. Second important thing is take bigger bites. ऊपर जब टच करते तो प्रेस करके and then take the full bite. So don't leave it halfway, otherwise they keep on hanging inside. Another thing, suppose आपको करते करते you find a bleeder somewhere, you increase the pressure, bleeder stop हो जाता है, but coagulate that bleeder. So slightly reduce the pressure, see the bleeder, coagulate and then go ahead. Otherwise, all the fluid is entering into the open vessels, and you will not realize when suddenly the patient anesthetist will say that I can feel some cramps, and she's having a low saturation. So all these things should be kept in mind. Don't get carried away. And also at some time you can use the mechanical effect of the loop. तो corners के ऊपर कभी कभी there is, so rather than going on the mucosa, आपका जो ये edge है resectoscope का, mechanically just lift it up, it comes out and then go for the thing. Another thing, suppose you are not able to complete it, you can come out, just do a bimanual massage and go back inside. If at all you have to come out at any point of time during the surgery, too many pieces floating inside, you are not able to see, or sometimes a piece gets stuck onto the lens and you cannot see anything. Very, 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 very important. आप बाहर आ गए, cervix is open, okay, dilated, vulva is open, patient is lying, and you are telling the sister, you clean this scope and give it to me. इसके अंदर ये अटका हुआ है. She is cleaning it. Till then, there may be some blood vessel which is open. The cervix is open to the air, the vulva is open to the air, and the air embolism the air can just gush in. And once air find its way, it will just keep on going inside and you have a major complication in hand. So whenever you take out your instrumentation, pinch the cervix, close it, or take a mop and keep it on the vulva. So make sure the air does not go inside in between the procedure that you are doing. Now, again, for small fibroids and even for, other maybe polyps and retained products, this is a Bugatti shaver that I'm using. All these tissue retrieval systems are amazing. It does not take more than 5 minutes. It causes both suction and cutting at the same time. So अभी आपके पास एक ही फुट पैड है, you don't have two, मतलब you can't use two, right? With 1 foot only you can use. So you press the foot pad, it starts suction. You press it harder, it starts cutting. So cutting and suction both are happening at the same time. You just oscillate it left and right. Make sure you're always superficial. Don't go deep. The moment you go deep, then again you have a problem in hand. Uh, Later that you have damaged the basal layer, and then you have adhesions and the patient will have problems in conceiving. This is another case. Here you can see it is actually a FIGO 1 or FIGO 2 fibroid, where more than 50% or maybe most of it is intramural, and there is nothing which is coming out into the cavity. A good mapping was done. Then you give a small cut with scissors all around. Okay, so this is how a small cut. Now, after giving this cut, there are some studies which say कि इसको ऐसे ही छोड़ दो. Okay, patient को एक call her after 1 month. This fibroid automatically will come into the cavity and will become FIGO 0 or FIGO 1, and then you can comfortably do it with a resectoscope. Here I have tried using a hysteroscopic myoma screw to make it from FIGO 2 to FIGO 1, and then go ahead and do a resectoscope, use the resectoscope. Don't try to pull it out completely, because this is a very, very delicate 5 French instrument. It will break, and then your screw will also be inside and you won't know what to do. So just very delicately bring it into the cavity, take it out, put your resectoscope, and with the resectoscope, then you can go ahead and do a resection just like you would do for a FIGO 0 fibroid. Then this is another lady. She's 33 years old. Husband has oligoasthenoteratospermia. She has a 3 centimeters intramural fibroid. What to do? Should we operate? Should we not operate? What does the evidence tell us? Evidence is telling us that you can operate. Intramural fibroid appear to decrease fertility, but the result of therapy are not clear. So we are not sure whether this will help her or not, and we can discuss the options with her. As of now, do not touch, and we can just go ahead and treat, do ICSI for her and go ahead. But if you have counseled her, you also have to give her the possibility of a early pregnancy loss because of the intramural fibroids. You should know about it. And if she still insists that I want my everything to be fine, well, yes, we can go ahead and operate. So but however, if we have a similar 4 centimeters intramural fibroid which is impinging the cavity, then the evidence tells us that these fibroids should be operated, and we should go for myomectomy. All right, then of course, metroplasty is another surgery which is favorite for all of us. We love doing metroplasty. We love doing septums. It's such a fantastic, very fast 5 minutes it takes to do a septum, and we can either use a monopolar, bipolar. This is a case of complete septum. Now, one small tip I will give you: whenever you have a complete thick septum, okay, initially you may find it difficult to use your Collins knife क्योंकि वो पूरा प्रेशर आपका चला जाएगा. So you can use scissors or a bipolar needle, but scissors are much better. So शुरू में use scissors. See here, I'm using scissors. Scissors is much better to use. And once you reach little higher up, then you can use a Collins knife, because scissors are very delicate, and if it is a thick septum, it costs also, they are expensive. So Collins knife is a better option once you reach the higher up. So once you reach little higher up, you can see over here, then I am using a Collins knife here. You first create a level up to which you have to go on both the sides, and then you can go ahead and just snip. If now you see the ostia, that is the level that I have to go till. Don't go right from the middle continuously. Go from the lateral side, create a level. So when you're going in the center, then you know that I have to reach till that level. These are just minor things, but they will really help you in your practice when you are doing these cases. This is another case where she had a complete septum. Actually, picture में यहाँ तक है, but she also had a vaginal septum. No, but she had no problem with intercourse. I mean, there was no sexual dysfunction. So what is the idea here? We want to increase the size of the cavity, but we do not want her to have any kind of a cervical incompetence, right? So you cut the septum from here to here. Now, when you are cutting the septum, आपने यहाँ से hysteroscope डाला. When you are cutting the septum, the moment this gets exposed, the water will come out from here. Okay, so you will not get a extension. So you put a Foley's catheter here, inflate the Foley's bulb, and then you do the resection. Another advantage of this is that you see the Foley's bulb coming in when you are resecting. So here you can see the Foley's bulb already seen. This is a bipolar hook. Actually, I had got it designed from my local person, and this really works very well. So this is a bipolar hook. So just go on cutting till this Foley's catheter comes inside the cavity. You can see here. Now slowly the other side is coming in picture. Whole of the Foley's catheter is coming. You don't have to completely cut at the tip, then you can use scissors. So whenever you have to do more finer procedures, and scissors I find have a better control, and then you can use it. So this is how the whole cavity can be created in such cases, and the complete Foley's is inside. We have a good cavity, and then this patient actually conceived on her own. Another thing which we have to keep in mind is the possibility of an isthmocele. So, whenever you're doing an ultrasound for a patient who has had a previous surgery for a C-section, look for an isthmosyle. 50% of the times she will have no symptoms. Okay. But once your eyes get tuned to looking at the isthmosyle, then if she comes with a post-menstrual bleeding, spotting, foul-smelling discharge, secondary infertility, and previous history of C-section, and then you find that there is an isthmosyle, look at the residual myometrium. This is the residual myometrium. If it is more than 3 millimeters, she's keen for pregnancy, you can treat it hysteroscopically. She's not keen for pregnancy, 3 millimeters or even less, you can go ahead for hysteroscopic management. But if she wants pregnancy and the residual myometrium is very thin, in that case, it is better to go laparoscopically. So this is how hysteroscopically, and this is the level of isthmus. Again, very important. This is at the level of isthmus. Whenever you are doing a hysteroscopy, always look at least 12 places. So fundus, anterior, posterior, right, left, again mid cavity, and at the level of isthmus. ये 12 जगह देखना है. And then when we are coming out, even in the cervical canal, sometimes you find a small those cyst there. So they can cause leukorrhea and they can be punctured when you're doing a hysteroscopy. So this is how you find this is an isthmosyle here. You can use a resectoscope, very, very good. Or you can also do a bit of coagulation at the base, level it out, do a coagulation. Or if you don't have resectoscope or you're not able to use the resectoscope, just take a sharp curette. Take out your hysteroscope, take a sharp curette. Now you know visually where it is, and just do a nice leveling with the curette and then go again and check it out. So this is how you can manage isthmosyle with and you have to go do it ulta because it is on the anterior wall, and then you can go ahead and do a resection of the thing. Then sometimes some patients you have very small cavity, especially patients where it is a unicornuate uterus. Though sometimes of course you can do a lateral metroplasty. Very now the indication is not so much, but very T-shaped, very small cavity. Never cut at the fundus. Okay, fundus is very thin. So if you go and cut at the fundus, perforation chances are very high. Lateral walls are thick, so you can give a nick at the lateral walls. Then, of course, there is a role of PRP, which you can do hysteroscopically in create a PRP, especially patients of thin endometrium who are not responding to your whatever you are giving, vitamin E, estrogen, sildenafil, GCF, then intrauterine PRP, all of that you have done not working. So you can try using hysteroscopic injection of PRP at the junction of endomyometrial junction. So do it at 4 sites and inject about 1 ml at each site. And after you have injected, wait for a few seconds, come out, and then go to the other side. So this is how this is how you go and you inject and then you come out. So this is actually, we did an original study, and we also published this study of ours of hysteroscopic injection, and we did it in the luteal phase of the previous cycle, and this was our publication on thin endometrium, where we used hysteroscopic instillation of platelet rich plasma. This is how we are making the PRP. You can take a picture of this. Earlier we were using it with a single wire, but then we realized that with this 3 wire, actually I learned it in another IVF center in Dubai. This is how they're doing it over there. And I realized that we get a good concentration of platelets. And secondly, that by doing a freezing and thawing, you put it in the incubator, then thaw, and then again put it and again thaw. So that causes an activation of the platelets, and they are probably more effective. So thank you very much. I think I finished just on time. And if we have any questions, I can take them up. Thank you very much.
Excellent talk, ma'am. Very comprehensive as always. So I
Thank
feel there is a very thin line between over treating a woman with a hysteroscopy and using it at the right time. For me, normally it comes in a case of recurrent implantation failure with good quality embryos. So, so we can there we can think about doing hysteroscopy, and we do see magical results after hysteroscopy. Immediately in the next cycle, they sometimes they tend to conceive, especially
Right.
those sinister sinike. I call them sinister sinike, which are missed on scan. So they can be picked up on hysteroscopy. So
Another
excellent
small
talk.
tip, sorry, another small tip for the my junior colleagues, that whenever you are doing any polyp, I was just looking for the video, it's not there, on the wall, always use scissors with one end moving and one end static. Don't use scissors with both ends moving. You will have very high risk of perforation. Only for septum you can use with both ends moving. For the side wall, anything, use one static and one cutting. So that will be, sorry to disturb you, Yukti, in between. Thank you.
Yes, we all love doing metroplasties.
Yes, yes, thank you.
Oh,
Uh, thank you, Dr. Meenu. Uh, Everybody will agree that it was really an excellent talk. She started with the very basics and then ventured into the most difficult type of decision making and surgery. And she has given a lot of hints, lot of tips to our uh, uh, new and upcoming hysteroscopic and infertility practitioners. Uh, Dr. Meenu, it was excellent talk, but I will like to clarify few things from you because there are many youngsters here. How do you make a decision whether this patient requires cystoscopy before going in for any procedure, or your practice is putting cystoscope in all patients? What is your views on that? Because this is very debatable area. Though we know that histoscopy is required in some of the patients, but when it comes to the decision making and policy making, there are a lot of debates.
Yes,
So, what is your input on that, and what is your practice?
yes. So as per ASHRAE guidelines, we there is no
No,
in
leave aside guidelines. Leave aside
okay.
guidelines because
Hmm.
guidelines are there, but we are breaking these guidelines day in and day out in our clinical practice just to give a benefit of technology to our patients. So whatever uh, we feel that this is right, we continue to do that, and after some time, that comes into the papers also. Okay, so the guidelines and uh, uh, evidences, they keep on popping up every few years. So, what is your message? Like, what is your practice, and what is your message to our youngsters?
So in my practice, I don't do hysteroscopy for everyone before IVF. I do for all patients where I find a pathology, which everyone would do. If I am monitoring the endometrium in an FET cycle and I find that the endometrium is not growing that well in spite of doing everything, I will do a hysteroscopy for that patient. However, some patients, like a young patient with male factor infertility, good endometrium, good ovulation, I think I will not do the hysteroscopy at all for her. So it is a decision making one to one. It is not for all. As of now, I don't do it for every patient, but only the patients where I feel that yes, let me check the cavity, why the endometrium is not going, why it is homogeneous, why the endometrial lining not as echogenic as the myometrium. If it is less echogenic than the myometrium, or if I feel that it is a homogeneous endometrium even in the follicular phase, then I would do the hysteroscopy. So again, patient has scanty cycles. I suspect that maybe there are intrauterine adhesions. One point I forgot to tell you, after the intrauterine incision adhesions that we cut, then use a Foley's catheter. So what you do is you cut the tip of the Foley's catheter. Okay, otherwise that occupies all the space and it comes out. So cut the tip of the Foley's catheter, then you place it inside and then you inject about 1.5 ml of normal saline. Stick it by the side of the thigh of the patient. Once she's just in case you have done it under anesthesia, then sometimes they can get a little pain. If they have pain, उसको 1.5 ml से आधा ml निकाल दो fluid को from the catheter. Then she will feel relieved. Keep it for at least 12 hours, 6 to 12 hours, and the risk of addition reformation will be much less. Just yeah.
Ma'am, do
Thank
you give
Yeah, thank
Esterol also
yeah, yeah,
after
thank you,
necroplasty and all?
thank you for giving these tips. I think leave aside the debate. You should not shy away from entering into the cavity if you are having anything, even a small thing on ultrasound. Like there are many times you are not really looking at the uh, smaller things. So try to look on ultrasound picture very carefully. That is very important in decision making. Many times you are having a good uh, uh, egg size, follicle size, but that is not collaborating with the endometrial thickness. Okay. Now this is one thing which many times missed. You are not correlating. Yes, it is okay. Means next time you change the protocol. Still, it is not growing. It is very regular, but it is not growing. It is restricting itself at one point uh, in the cycle. These are the patients. When you put the hysteroscope, you will find something like either they will be walled endometrium or they will be focal areas of congestion or there will be subtle chronic endometritis which cannot be picked up on ultrasound. So I think these are the patients. And again, you are having very good endometrium, everything is looking good, but you are not getting your patient pregnant. Yeah, repeated failure. So these are the patients which
I think आप mute हो गए हो, Dr. Kuldeep. हाँ. Just unmute yourself. Dr. Kuldeep sir, आप mute हो गए हो. Just unmute yourself.
Yes, audible.
I think, Dr. Meenu, there are a few questions from the audience
Question.
also. So we can open up these questions and then you can interact directly. So any questions you can unmute and ask from Dr. Meenu.
So Dr. Shreyash Patel wants to ask some questions, sir. I would request you to ask directly. Dr. Shreyash, can you hear me?
See,
Am I audible?
if you are not able to remove the pieces, no, Dr. Shreyas, you can just put a smallest ovum forceps. Just go inside and the pieces will come out very beautifully. So you can use ovum forceps for that.
Hello.
And can we use
Hello.
vasopressor for resection?
Hello.
So,
Yeah, we can hear you, Dr. Shreyas.
Yes, ma'am. Yes, ma'am. Good afternoon, madam. Hello.
yes, good afternoon to you.
It's a very nice presentation, madam.
Thank
But it's my question that is very many time it is very difficult to remove that specimens. Even after using that OM forceps, even after using that small sponge holder, even and then it will take us so much time and bleeding also. So in between that time, that cavity is so much mash up, then we cannot remove all the specimen.
Mm-hmm. See, normally the cervix is dilated, so the moment you come out and you put your ovum forceps and you bring out one piece, the others also come out along with that. Otherwise, the urology people have a manual suction device which they put inside and they do manual suction and it comes out. I have used it in the past, but now I have not used it for a long time.
It is also not so effective, madam. I have already tried.
Okay, okay.
Its surgery is always that because fibroid is always difficult to do that.
Mm,
That is challenging surgery always. So that was very nice presentation, madam.
right. Yeah, yeah, yeah. I have not found it very difficult to take it out. Just use your ovum forceps. I think I find it the best. The smallest one. Don't you use big ovum forceps. छोटे वाला use करोगे तो उसके side में से दूसरे वाले pieces अपने आप आ जाते हैं. You
Okay,
take
madam.
one piece, the others also come out. If you use a bigger ovum forceps, then it will not come out. So use
Okay,
the
sure,
smallest
sure.
one. Yes.
Okay, thank you, madam. Another question is, madam, can we use vasopressin in this type of fibroid around 2 to 3 centimeter around fibroids?
Very good question. Now, there are two ways of using vasopressin. One is you use paracervical. Okay. So
Okay.
you leave 3 o'clock and 9 o'clock position. ये दोनों छोड़ दो यूट्राइन है वहां पर तो you can go 2 o'clock or 4 o'clock या फिर 8 या 10 तो वहां पर same dilution what we use for normal myomectomy one
Two
six
in two in
100 ml yeah
yes.
so same dilution, you can use it, inject it first and then do the dilution. Yeah, so that is one option that you can use it. Second, which we are going to publish now, what we have started doing is injecting the vasopressin through the 5 French side port with the ovum pickup needle.
Okay.
Just done in a few cases. We are doing some more and then we are going to publish it. So that is one more way.
Can we use, madam, with help of that OM pickup needle? Can we use that needle for intrauterine injection?
That is what I'm saying. So we
Yes.
put it intrauterine just under the, just like you do it for
Laparoscopy, yes.
same way. So we are
Okay.
already working at it and we have done a few cases and we will be
Okay.
publishing it very soon.
Done, madam. Third most common question is, I am in Wings Hospital with Dr. Jayesh, sir. He always say that don't use the cautery inside my cavity. So he
Yeah.
always try to prevent the thermal damage. So what is your opinion, ma'am?
See, coagulation, whenever you are doing, you are causing a damage. But pure cutting is like scissors. So if
Okay.
you're doing a septum with pure cutting current, this is working like scissors, it will not cause any damage.
Okay. Okay. Got it, madam. Thank you, madam. Thank you.
मैम पोस्ट मेट्रोप्लास्टी व्हाट इज द रेजिमेन आप ईस्टरडियोल देते हो मैम कितना डोज कितने दिन के लिए मैम पोस्ट मेट्रोप्लास्टी
Actually, if that patient is ovulating, she has good endogenous estrogen. तो उसमें अगर आप दोगे या नहीं दोगे, उसका estrogen is acting. However, if you still want to give, you can give 2 milligram 3 times a day, and you can continue it, give it for a month or so.
थैंक यू
I would like to congratulate you, ma'am. Minu, madam, you have so beautifully explained with use of various animations and various these short videos. It, it was very nice presentations, and our new delegates would have definitely learned. There are so uh, points regarding use of ergonomics and tricks you have explained very well. Thank you, ma'am.
Thank you. Thank you very much. Thank you.
थैंक यू IFS and Shweta ma'am for this opportunity and invitation. Thank you.
Thank you, Dr. Shweta Gupta ma'am and Dr. Kuldeep. Thank you.
Thank you, Dr. Minu. It was really a good talk and a good interaction, and I am sure that the participants have taken a lot of messages from your talk, and they will be really benefited. So thank you very much, and thanks Shweta and Mansi for organizing this really wonderful talk. Thank you.
Thank you, sir.
Actually, Dr. Subhash Malia, sir, he's busy in a surgery. So, I would request we have so many seniors with us. KD sir has joined, and Kuldeep sir is there, and Dr. Desh Deepak sir is also there. So, I would request the seniors to kindly share with us some tips and tricks about how we can avoid the complications in hysteroscopy and laparoscopy. Meanwhile, sir is just, he'll be with us very
आपके व्हाट्सएप पे
shortly.
लिंक आया होगा इसका मीटिंग का
One more thing, Mansi, which I did not mention. Suppose आप ऑफिस हिस्टोस्कोपी कर रहे हो, हाँ, आप अंदर चले गए अंडर विजन वेरी नाइसली, बट देर इज नो डिस्टेंशन हैपनिंग. यू इंक्रीज द प्रेशर टू 100, 120, 140, but no distension happening. So sometimes the cervical internal os is loose. It is more loose than your hysteroscope. So the fluid is coming from the side. So there you put a sim speculum, hold the cervix with your valcellum, and immediately you will have a beautiful vision. So that is something you should know about.
So Mansi, he will be joining soon, isn't it?
Uh,
How, Dr. Meenu, it was
he has just messaged in 5 minutes. He'll be free.
yeah. So Dr. Meenu, it was a
So he'll be.
fantastic talk. And just wanted to ask how many times you have to counsel for the second look laparoscopy? Do you think that is very frequent and um, or pre the first case where you expect, like an Asherman or something like that, where you have to counsel that the patient may require second look hysteroscopy?
Yes. So, ek to whenever we are doing a hysteroscopic myomectomy, 3 centimeter fibroid, 4 centimeter, we feel we are, we can do everything. So, we sometimes don't tell the patient कि 2 sitting lag sakte hain. So, we must tell the patient कि there can be 2 sittings or maybe more than 2 sittings required. Should not get carried away. So, if it is taking a lot of time, stop it in between, come out and do it at another sitting. Secondly, when I'm giving only the incision at the level, at the mucosa, at the endometrium, exposing the fibroid, FIGO 2, FIGO 1, then I do it in the next sitting. Another thing, when we are doing the adhesions, so there also before the embryo transfer, if we are not getting a good lining, many a times we do another second look hysteroscopy and office hysteroscopy again as a second look. And yeah, so these are mostly the cases where I would second look hysteroscopy. Yes.
Yeah. Yeah. Thank you.
In our city, it's quite difficult to counsel patient for one-time hysteroscopy.
Yes.
Right.
Yeah.
I mean, in every city is difficult, madam. In every city it is difficult.
How to charge?
See,
in
and
say-
office cystoscopy is actually they get convinced proper nicely, but I always tell my junior colleagues that do at least 40 to 50 office cystoscopies under anesthesia. यानी आप पेशेंट को एनेस्थीसिया दो बट स्पेकुलम टनेकुलम कुछ मत यूज करो. Go like as if you're going without anesthesia. So get your bearings right. And then when you are doing it without anesthesia, you are more confident also while doing it. So then the patient gets more confidence
Hello.
on.
Yes, sir. Desh Deepak, sir, you are.
हाँ
audible.
मैडम, I'm from Kota. I think proper counseling is very important before any hysteroscopic surgery, and before planning any hysteroscopy, proper mapping is also important, as you already mentioned in your sonography. So if the myoma is bigger or any pathology, then we can counsel beforehand, मतलब starting the surgery, that it will take 2 settings. And sometime in such cases like big myoma, I also counsel if need arises, then we will do laparoscopy in same setting. If you are telling that it should be done in the same setting, so demand our counseling before starting the surgery. And anesthesia part is also very important. If your anesthetist बोलते हैं कि भाई अब बंद कर दो, then we should stop the hysteroscopy surgery, because there should be more मतलब aware. They are monitoring each and every things, because we are vigilant in operating, but they are should be alert, so that they can warn us that stop your surgery.
So
Sir,
whenever
in
the
terms of this,
diastolic
Deepak sir, as you
pressure,
rightly said, I think
yeah.
Yes, yes.
we'll cover the hysteroscopy.
हाँ, सुभाष माल्या सर आगे क्या?
No, ma'am, I said the hysteroscopy will cover here only, sir.
Yes, 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 yes. Only hysteroscopy.
नहीं
Yes,
सर,
sir,
मैं
yes.
यहीं पे हूँ, लेकिन प्रॉब्लम ये है कि सर मुझे नहीं हिस्ट्रोस्कोपी में सर, एज यू राइटली सेड, Sir, there is no point, I think always it's very, very imperative that we take the opinion of the anesthetist, sir, because what
Yes,
happens
yes.
is, I think we are so much engrossed in the surgery that we will never understand the fluid overload has happened. And I will always tell my colleagues, whenever you do under GA, look for two things. If it's an office hysteroscopy, good, because the patient herself will tell that no, she has some difficulty in breathing. But when it comes down to an hysteroscopy, always look for the saturation. If your saturation SpO2 goes less than 92%, that means that the patient is going in for a failure, a cardiac failure. So have that in mind always, keep in mind. And again, in sort of embolism, in case if you've done a case under GA and you have an ETCO2 monitor, and if your ETCO2 goes zero, think in terms of embolism. So never ever forget these things. Saturation probe is very, very important. And don't be मतलब मैं कर सकता हूँ, मैं ही कर सकता हूँ
Ma'am,
और कोई नहीं कर सकता, ऐसी
and
चीजें कभी सोचना नहीं है इन हिस्ट्रोस्कोपी.
yes,
Anesthetists
yes.
कहते हैं तो no ego, nothing, zero ego, stop it, because it's so very difficult to revive the patient under once she has gone for a failure under this thing. It's so difficult.
We
Yeah.
should always see the neck of the patient also. Sometimes there is swelling in the neck,
बिल्कुल, बिल्कुल, बिल्कुल. I
or
always say there has to be a very, very
uh,
pragmatic approach, not
very.
dogmatic approach in such cases.
So complication of hysteroscopy is more dangerous than the laparoscopy, I think so. If you
And
ever
again,
encountered.
there, if you really ask, because most of us,
Hmm.
if you go by what we do, sir, is that whenever we're doing laparoscopy, we're always very, very, हम चौकन्ने रहते हैं कि कोई
Yes, yes, yes.
मुश्किल लोड है, हम हमेशा चौकन्ने रहते हैं.
हाँ
लेकिन
हाँ.
हिस्ट्रोस्कोपी we always take it so lightly, इसमें क्या बड़ी बात है, ये तो कोई भी कर सकता है, ये तो बहुत आसान है, बहुत simple है. And that is why you see almost 60-70% of the complications are always in hysteroscopy, and laparoscopy is very, very rarely, sir.
And
It's not that your casual attitude, because we feel that it is easy, ये तो बहुत आसान है.
yeah. And another thing, whenever we are dealing with a large submucous fibroid on hysteroscopy, we can also give GnRH agonist. Two
Yes, yes, ma'am.
cycles, three cycles, it shrinks very beautifully. And then the bleeding is also much less when we are resecting it. So that
Yeah.
also possibility we should keep in mind.
Mm.
A
So I
huge.
think we shouldn't rush. I think the selection of cases, preparation, mapping, consenting, counseling, all plays important role. Yeah, Dr. Desh,
Absolutely.
I think you wanted to.
Gita madam, as you
Mm.
rightly said, but मैम मीनू मैम एंड
Uh,
श्वेता मैम, स्मॉल डाउट, अगर हमारे पास कोई फाइब्रॉइड है सबम्यूकस टाइप 0 अगर 4.5 सेंटीमीटर 4 सेंटीमीटर है, so am I
Mm.
wrong in going laparoscopically, madam?
Subhash, are you asking me? You are the boss.
Yeah, I am asking all the seniors, ma'am. I'm asking all the seniors.
Yeah. No, you can go laparoscopically, no problem at all. See, whatever we feel that I am more confident to do it this way. So, if I feel more confident to do it laparoscopically, 4 centimeters intramural submucosal fibroid, only patient is ready to wait for 3 to 4 months before the embryo transfer. You are not touching the lining at all. It's a very good option. Yes, I agree with you.
Because sometimes what happens is, कभी कभी hysteroscopy करने की मतलब in this enthusiasm, we may cause more damage to the endometrium than doing a good thing for the patient.
Agree
So I
with
think such
yes, sir.
cases doing a myomectomy, a lap myomectomy may be a good option, but not for small submucous, for the bigger submucous fibroids always.
Yeah.
Thank you, Subhash sir, Deep sir, madam, and Minu ma'am. I think without
मैं
further
बंद करूँगा.
move ahead, and I would like to invite Subhash Malia sir for next session regarding complication in hysteroscopy and laparoscopy. Before that, I would like to invite our chairpersons for second session. So Karanji, please, TVs. So our first chairperson is Dr. Kannad Dev Nair sir. He is immediate past president, Indian Fertility Society, convener Education Committee, Indian Fertility Society in 2018 to 26, and chair-elect ISIG ASRM. He has various publications and presentations in various ASRM and SHARE meetings and had won various awards. Thank you, sir. I welcome you. Our second chairperson is our favorite, our own mentor, Dr. Deep sir. He is organizing secretary, West Zonal Yuva Foxy Conference, organizing chairperson, state conference, AGSR Con, our first IVF baby, and our first endoscopic center in Kota Hadoti region is under the name of Rajdeep Fertility Hospital and Research Center, Kota. So you are our mentor, sir. We welcome you. Next chairperson is our Dr. Shweta Gupta ma'am. As I already told, she is convener of IFS Delhi Forum, and she is director of IVF Max Super Specialty Hospital, Delhi, Noida. So I welcome you, ma'am.
Thank you.
Thank you, ma'am. I would like to invite Kannad Dev Nair sir for inviting our speaker, Dr. Subhash Malia sir.
Good
So,
afternoon. Thank you very much. It is my pleasure to invite Dr. Subhash Malia. He is a renowned endoscopic surgeon and is the chairperson of Foxy Endoscopic Committee also 21 to 25 and Secretary of Kerala Federation of Ops and Gynae Society 24 to 27. He is a managing committee member of AIGE 24 to 26, peer reviewer for Jogi and IGA Journal onwards, 24 onwards, and Foxy Mental Award 2019, authorized 15 chapters. Welcome, Dr. Subhash Malia. We would like to listen to you. What are the complications you can encounter during hysteroscopy and laparoscopy?
Subhash Malia sir, are you there? I think he has left by mistake. I can't see him. Karanji, please check if Subhash Malia sir is there.
Sir, already it's there, ma'am.
ठीक है.
Madam, is my slides visible, madam?
Yes, sir, visible and audible.
Yeah, thank you, ma'am. Thank you very much. Actually, ma'am, I was driving. That is why I finished my case. I was driving. I'm really sorry, sir. I've reached my place. I've stopped my car. Right. Thank you very much, KD Nair, sir. I didn't know that you are the chairperson. I'm very, very happy and great that you are the chairperson. And it's a privilege, sir, for me also, sir. In the meantime, sir, yeah, I'm sorry. And Shweta, madam, thank you very much for your patience. And I sincerely apologize because I had a case which got delayed. And I'm really sorry. Desh Deepak, sir, thank you very much again, sir. I would like to thank IFS for this wonderful opportunity again. And coming back to the topic per se, let me go down to topic per se. We all understand, this is a very nice slide. Said, best of Boeing, the best of
Sorry, voice is not clear, sir. Sorry to interrupt.
Is it okay, ma'am? Now is it okay, ma'am?
Yes, sir. Now,
ma'am,
Yeah,
now is it
we
okay,
can
ma'am?
hear.
yes, sir.
Yes.
Okay. Now, is my slides visible, ma'am, now?
Yes, sir. Yes,
Are the
sir.
slides visible now, ma'am? Yeah, okay.
Yes.
What remains untold
Yes,
is
yes,
most
yes.
important because the problem that we have is we are always in this bad habit of hiding our complications. We don't talk about the complications. This is something which is very sad. And I always believe we must always open our, we should share our complications because that is when somebody can learn. I keep repeating this very often, that experience is nothing but complications. It may be somebody else, it may be yours, but as long as it's been shared with others, only then we would be learning about this. Right? Now, you can have your dream car, you can have your dream road, but still, things like this can happen. Now, the importance of this, what I said, is because you can have the best of instruments, you can have the best of theaters, but still, in spite of having the best of instruments and best of 3Ds and robotics, you can still go wrong. But what you have to understand over here is it's not always the fault of the doctor per se. Please understand, accidents can happen to the best. They can pull your down your confidence, but of course, it gives you an opportunity to improve in life. You can see this car. This is a small car which looks very simple. But please understand, these are the number of things that have to go, to making this car out. Can you see this? So, it's not always the surgeon per se. A lot of things can go wrong. A lot of things can be right. But this is what happens always. Good surgical decisions always come with experience, and experience comes with complications. Okay, but it's very important that the lessons that we learn from a surgical mistakes are very, very important. Now, we all know the advantage of laparoscopy. I will not go into the depth of it, but the disadvantage of laparoscopy. Of course, we know it's a limited view, the energy source and the heat transmission, the teamwork.
Sometimes lack in training. You can have the residents coming, you can have the fellows coming, some new fellow will come. They will take some time for you to adjust it to your style of surgery. Of course, that again can cause some amount of issues. The complications cannot be hidden in laparoscopy. It's a good advantage of laparoscopy. In types of complications we have the surgical and the non-surgical. The non-surgical again belongs to embolisms. So always putting in a DVT stockings, or for that matter, even a calf pump is always a good idea. Burns from the light source would look very simple, but believe me, I always scold my fellows, that you cannot put your light on the abdominal burn. No, it's a very focused one. Maybe 1 minute, maybe 90 seconds, you can have a burn. And because I'm telling you about this burn is because, one of my senior colleagues, pro, I couldn't take out the name of that senior pro. He had a case in the court of law for almost about 15 lakh rupees for this cautery, for this light burn, To be very, very careful about this. To be very, very careful about this stuff. Now, next is regarding the surgical. Please understand we have different type of pathologies. We have difference of in size, in shape, in space, in sticking and spurting. Now, all these are difficult pathologies. I said the 5S, which always matters, There is no need for fiction in medicine, remain Foster. But of course, that's what again is. Now, pre-op, intra-op, and post-op. These are the three types of complications which we normally have. Pre-op regarding the bowel preparation. I do not believe in a very aggressive bowel preparation. I always believe that the patient would have this very simple tab bisacodyl previous day twice. DVT prophylaxis, yes, I would always give a DVT prophylaxis to all the patients because I work in a hospital where the calf pumps are always ready. Antibiotic prophylaxis, yes. Specific recommendation anesthesia, it's not much. I don't say that, but please understand that bowel preparation, there are no current RCTs that this is good and that is bad. Whatever you're likely to, you're comfortable with, whatever is your hospital protocol, go with a particular protocol. The risk of DVT after benign surgery, unless and until there are risk factors like, diabetes, hypertension, very obese, the surgery has taken more than about 3.5 hours, 2.5 hours, yes. Methods available, I said, DVT calf pumps, you can put the gauze, you can put a wrap a bandage also, you can do that. Now, combinations of mechanical and pharmacological can always be done. But of course, if it's a high-risk patient, always think in putting in previously a case of heparin also, not prior to the surgery, very much prior to the surgery. Okay. Now, GA is always preferred in such cases. Intubation with no mask is better. But please understand that when you do a pre-oxygenation, always, because most of us put the Palmer point, they always try to deflate the stomach in such cases. You deflate the stomach in such cases, what happens is the chance of going into the stomach because of lot of bag and mass ventilation goes very less. So do avoid, if you're putting a Palmer's point, always try to deflate the stomach. Okay, that is one tip which I would always give it to you. Okay, now the other one again is again over here. Wait 1 second, please. Is now position. Patient position is very, very important. We give the dorsal lithotomy position always, but it's not basically a dorsal. I would always prefer to tell that the buttock of the patient should always be beyond the tip of the table. Because when you give head low, the patient actually goes down a bit. So what happens when you put in a specimen retrieval for your hysterectomy, it becomes slightly difficult. Okay. Now, this is actually the position which I would always prefer. Now, entry techniques, I will sum up the discussion of entry techniques. You can put any technique that you want. Anything is fine as long as you're comfortable. I personally prefer a supraumbilical direct entry, but you can always go for Palmar or anything is fine. But in terms of, your medical legal aspect, please understand, you put in a primary trocar and do a problem, not an issue. But you're not pardoned by the court of law if your problem is when you put a secondary port. If you put a secondary port on, it would be a big, big problem, if you can cause any damage to that. Secondary ports, it could be ipsilateral or contralateral. Of course, never in a straight line is what we say. It is direction of insertion at the time of entry is very, very important. Please understand this. For a normal weight patient, you go at 45 degrees. Okay. For an overweight patient or an obese patient, you always go a direct at 90 degree. Please understand this. Okay. This is very, very, very important in such cases. So normal weight patient, you go at 45 degrees. And when you go at 45 degrees, the advantage is, the advantage is you always have this. I'm sorry for this. Okay. Is that, 45 degrees, you will not damage us. Whereas over here, you can see there's an overweight patient, you always get 90-degree angle. Okay. So please understand, aortic perforation is always cephalic to umbilicus in obese patients. Okay. Now let's say the same thing again over here, that is the percentage of this. Now, high pressure entry, you can always put in a high pressure. I always believe putting it, if you're putting a Palmer's, you put your entry at approximately at around 20 millimeters, so that what happens, the abdomen gets distended. the chance of damaging into the aorta or to the vessels are very less in such cases. Okay. Now, if it's a scarred abdomen, like this abdomen's like north of India, we have all these patients with tuberculosis is much more common. It's slightly more difficult. Be very careful about such cases. So you have to choose your. I actually would like, either you can go for the Jane point somewhere over here, or the Palmas point over here, or for that matter, over the supraumbilical also. Again, I says it depends on your comfort. Nothing like I would not say that this is good and this is bad. Okay. Intraoperative complications are raised by bleeding, vascular, ureteric injuries. Now you have to be very, very careful in this. This is not my video, this is a video of my teacher over here. So please understand, this is actually when your lymphadenectomy was done, it's an inferior vena cava bleeder over here. There's a venous one. So what you have to do is always go and hold with the left hand. The importance of this is go and hold the vessel in the left hand, the bleeding stops. Then you can take time, do what is necessary. If necessary, you can call for your vascular surgeon or somebody. But of course, use your left hand. At that point of time, be very careful, fix it over, and that is very, very important. Again, another bleeder over here, you can see over here. You're doing this, over here. A lot of fumes are over here, so but it will be slightly difficult for us to understand. But please understand over here, when you're doing a lymphadenectomy over here, this is the external leg artery also over here. Okay, so first thing that you need to do is go and hold it, as has been done here. If you're a good suture, you can do good suturing. Always, you can always go in and actually suture with a 5-0 or a 6-0 Prolene. That is done. But if not, you're not comfortable with this, go ahead and call the vascular and open the patient. There is nothing like, you should not use an open surgery. No, you can always go for an open surgery. The most common vascular injury is the laceration of inferior epigastric artery, which is the only branch of external leg artery. Transillumination, many of them would have been taught to use, and transillumination is a good option. But believe me, transillumination doesn't help you out much with these things. It doesn't help you much. Okay. So always it's better to go forefinger blade lateral to the midclavicular line or to the primary port, and your chance of going in for a vascular injury is very less. Now, please understand this is very, very important. The difference between arterial bleeding and a venous bleeding. It will be very, very important for this. Okay. Please understand about this that you can see here. Arterial bleeding is always easy to identify. There is always a spurt. So be very careful with the spurt. You should not go near the close and then have a spurt. Keep the left hand free in terms, that shouldn't be having a grasper for that. Okay. And I can always use a clip, sealing, or a suturing. But please understand, back it's a venous bleeding. Packing or compression is also good enough. You can also use a bipolar. You can also use a clip. But if it's a one, when you have a carbon dioxide, please understand that you can have a carbon dioxide embolism also in such cases. Okay. But as I said, bipolar is good, but vessel sealer, the new kid in the block, is very difficult because there is a lack of adventitia on the veins compared to the arteries. Hence, when there is no adventitia, that is when you can always cause a lot of problem with this. Okay. Conversion to open is never a crime. Please don't feel bad. Now, these are two important which you have to be very, very important. This is called as a Satinsky's clamp, which you go in and hold in terms of your budget. Failure to open is not an issue at all, always better. Now, thermal injury is very, very sad. There's a very sad photo of, of a rabbit over. You can see this. Okay. You always use the cutting current as much as possible than the coax because it sticks on in monopolar always. Of course, if you have small amount of bleeding, you can use fibrin, gelatin-based tissues, and other tissues. Now, ureteric or bladder injuries, very, very important. You can see over here, this is a video of my friend Dr. Manjula Madam had shared with me. You can see here. I always please do remember that, whenever you do a dissection, the principle what our teachers have taught is always the same: traction and counter traction. Traction and counter. Over here, you can see the traction is bad. Can you see this? The traction is bad on the left hand. You're not doing a good traction over here. And see, you're not able to see over here. What happens is ultimately you can see over here, I've opened up the bladder over here. And the reason for that is not much of good traction over here. That's very bad. Again, a similar one. This is much better off. You can see over here, there is not much of a traction over here. Can you see this left hand is not pulling it pretty well? I'm going on cutting and I'm going on cutting. And this is what happens. Again, over here, you can see this is how this suture is over here. You can suture it with the vicryl number 20 or 30 or the new kid in the block, that is the barb sutures. But please take care that you suture it in 2 layers always, not in single layer, in 2 layers. Okay. Now, if you can see the Foley's bulb, nothing bad. You have to please remember that diagnosing an injury is more important at the table than later on. Okay. You can always visualize the Foley's bulb. You see the distension of the urine bag with carbon dioxide. You can also see the drainage from the leaking. If it's a very dense adhesion, you're not able to see anything, always you can inject methyl blue and see for any leak in that places. Okay. Of course, cystoscopy is a good option. If you don't have a cystoscope, you can always use a hysteroscope to check it across. Okay. But in case of prevention, please understand that if you're not able to see the edge of the bladder, fill the urine, the bladder with about 20 to 30 ml of saline. Sorry, not 20, 200 to 300 ml of normal saline. It gets delineated. It's easy for you to identify that. Okay. But do a cystoscopy end of the surgery. That's what I would always suggest to you. Again, over here, you can see over here, a similar one over here. You can see here. Can you see that the ureter is actually, there is a small transaction. This is how you put a stent. Okay, you always put in a stent in case you are in doubtful. And you can always suture it. You can see this ureter anastomosis because the distance is good enough way over a stent. But do not remove the stent. Do not remove the stent for at least 6 to 8 weeks, because that will be always be helpful in such cases. Okay, because over the stent, it's always easier for you. It's always better for you. Hence, this is always better in these cases. Okay, now the most common site is the pelvic brim. The most common type of injury is the avascular necrosis, which is due to the bipolar. Most common activity that leads to injury is you go on catching it, trying to coagulate, catch it, coagulate. Don't do that always. Always lift up and then you check out and then you use your surgery. That's very, very important again. Now, in terms of broad ligament, fibroid, and everything, you actually try to always cut the posterior layer of peritoneum when you do a hysterectomy, because when the posterior layer of peritoneum goes back, ureter also falls back. You always push the vaginal manipulator from below or actually pull the uterus from above. That would actually help you out in terms of your manipulation also. This is very, very important for such cases. Identify the ureter if possible. Dissection of the ureter is not necessary always. It's always safer to do, not dissect it. Now, of course, if you've seen, this is how the clinical management. If you have an intraoperative period and you've seen obvious dye, you do a stent. If it's a minor injury, use a stent, it's good enough. For a minor leak, stent is good enough. You don't have to suture or do anything. But it's a major one. If it's a distal one, you always do a ureteric reimplantation. If it's a middle one, you do an end-to-end anastomosis with a psoas. And when it's an upper one, it's so sad, you have to go for a ureteroileoneostomy. Post-operative always put in a good cystoscopy with a stent always. Now, bowel injuries are very, very rare, but it can see here, no? This is very, very important. You can see sometimes you go through and through. If you have not checked the abdomen, you will lose this out. Please understand, you will lose this out. Hence, I would always suggest you that once you put a port, you go 360-degree, find the whole thing that you've gone through and through. If you've seen everything, if everything is okay, you don't have to worry. If not, if you've not checked for this, see here, you would have missed this. Okay. Now, what I'm doing is removing the tube, the port. Don't do that. Just keeping the tube there is very, very good because that will help you out in your understanding where exactly it is. Okay. Again, over here now, you can see here, this is actually, you're not giving a good traction over here. Can you give a not good? Again, as I keep saying, traction is very, very important. Not giving good traction over here. You can see here, there's a small injury over here. Can you see this? Small injury over here now. Okay. So what you do is you put a suture a couple of times over here, suture it off, and keep an arise tube. That would be good enough in such cases. Okay. Interrelated are actually lacerations. Intraoperative always, during dissection or during thermal injury, and you should understand how to recognize it. If you have an asymmetrical distension of the perineal cavity, think in terms of interrelated bowel injury always. Okay. When you aspirate, if you get the bowel mucosa, the bowel content, it's so sad, you can choose. You can see the gastric or a bowel mucosa inside the trocar, which incidentally is you're doing a colonoscopy in such cases, then it is a problem again over here. Okay. Intraoperative always. Inspect the bowel after sharp dissection is very, very important. Areas with serosa, hematoma or blanching also is a very dangerous one. You can see over here now. See, there's a fecal peritonitis over here. Can you see this? Now you can do a primary closure or a decline. But this is something which I'll suggest you. Always do a rectal insufflation test. That is, you put in air inside the rectum and put some fluid in the abdomen, in the rectal area. If you see air bubbles, that means you've damaged. If not, it's okay. Now, thermal injury you can see over here is very, very dangerous. In such cases, you actually take in a suture. And so what happens is these are mostly due to accidental ones. When you have an accidental ones, please see to that you don't step up on your cautery machine. You don't stamp on it. And that is when your problems do occur in such cases. Okay. If you have an increasing abdominal pain, distension, leukocytosis, and CT, that would be suggestive. But what I will tell you is, if you have any patient with unexplained tachycardia, okay, think, and after surgery, when it's a difficult surgery, think in terms of a perforation always. Okay, please understand this. Okay. Now, over this again, similar one. And if sometimes what happens, if you have an abdominal distension, think in terms of your subacute intestinal obstruction also. In such cases, the most common cause is hyponatremia and hypokalemia. So hence in such cases, hyponatremia and hypokalemia is also very, very commonly seen. Okay. So always check for your hyponatremia or hypokalemia in such cases. Okay. Next. Post-operative nerve injury is very, very good. Now, please understand that, in such cases, when you have a femoral nerve injury because of improper positioning, that's a very sad thing, So you'll have to give these patients on gabapentin and everything for almost about 2 months or so. That is not an easy one. Now, the next part is, please understand, defeat is not when you fall down. Okay. It is when you refuse to get up. So please, my ladies and gentlemen, please understand this. Get up every time you have a fall, but please don't fall every time. Okay. Tip to manage complications are always don't panic is the first thing. Keep your left hand free in case of vascular injury. Please don't forget that your left hand is always, always very, very important in terms of vascular injury. Self-confidence is very, very important, but not overconfidence. But please understand, conversion to open surgery is not a defeat. Opening a patient once is better than opening the same patient many, many, many times. Okay. So there should be no dogmatic, no such ego issues, I will not open. This is something which I really like to say always is never make a decision when you are, I think it's called as halt. That is, you stop yourself. Is again, when you are hungry, when you are angry, when you are lonely, that is without a team, and when you are tired. So don't do the surgery or take a decision for surgery when you're all these things. Last but not the least, always make a good start so that it ends well. So always prepare and think about the case prior to the surgery and not straight away go to the surgery. So please understand, think about what is to be done. Have a good idea of the case before you proceed always for such cases. Okay. Next is prepare and prevent rather than repair and repent. So always understand, have a good idea about the case and always, make a good anticipation of what can go right and what can go wrong. Now, in such cases, you should have to anticipate the problems in obese patient, in patients who are having a large inflammatory cases, inflammatory muscles, be very careful. Good surgical knowledge is very, very important. Good surgical plan is also important. Good team, good instrumentation, okay, and good backup. That is also equally important in such cases. But please remember this. I'm sorry for this. Is on conversion to open, as I said, egoistic approach should be condemned. Once open a patient many a times than opening many patients one many times. Law of averages is something which I would always like to share. Is law of averages is that please don't think that आज उसको कोई complication आई है तो उसको कोई problem नहीं है, आज मुझे कोई problem नहीं है, ठीक है. But never laugh at others because you will definitely have these issues. आज उनका दिन है, कल मेरा भी आ सकता है. So always be scared about this. Always be respectful of this and never laugh at the other surgeons because we will have some complications ourselves. Complications are always not natural. Some of them are due to less belief in force of nature and more due to over enthusiastic practice of the art. So be very careful. Know your surgery. Know your done. Only then use. Problem recognized. Problem half solved. And surgical skills. I keep saying this. Teamwork is very, very important. Okay, teamwork is very, very important, and it's good to learn from your mistakes, and it's better to learn from other people's mistakes. Is what Warren Buffett had said. So always, it's always better to learn from somebody else than your own mistakes. Okay, right. Thank you very much. I am sorry I went a bit fast because my anesthetist has already given me an ultimatum to start the surgery now, so I have to start it correctly. Right. Any questions, please?
I would like to
It
uh,
was excellent
Maybe, sir.
presentation, and you have very well highlighted the various complications one can encounter during laparoscopy and histoscopy.
Yes, sir.
Yeah, very well highlighted this talk.
Thank you, sir. Thank you, sir. Thank you.
Dr. Sweta, you have got any question?
No, sir. I think it was a very nice talk, and I think you have nicely highlighted the important points which young consultants should keep in mind, and especially, no ego, no feeling bad about it. Just do what is right for the patient, and also the life skills which you have told. It's always better to open it again if there is any doubt, rather than just thinking that no, ego should not be there. What is good for the patient ultimately, that is what is required to be done. And I think it was a beautiful talk, very well, timely, the nice inputs which you have given. uh, I think it was worth taking this talk.
Uh, In a very short time, Subhash has covered each and everything. And I think before planning any surgery, preparation is very important. And if there is any bowel injury, bowel preparation is also very important. And if there is any uritic injury, then also we should always Karan Arjun apne ready rakhne chahiye. We can call the urologist to help us. So in all the complicated surgery, our team should be ready to handle it on the OT table only. Then we can manage each and every complication. If in the OT table, then there is no any medical legal issue in the future. Thank you very much, Subhash. You have
Okay,
covered
sir.
each
Thank
and
you
every
very much.
complication.
Yes, sir. I would like to congratulate Subhash Malia, sir, for such a wonderful session regarding basic and most common complications during hysteroscopy and laparoscopy. Uh,
We can take one or two questions if anyone wants to ask any audience before we wind up.
Yes, ma'am. Please, ma'am. Please.
Hello.
I think, yeah.
बताइए sir, बताइए. Yes, sir, बताइए.
Subhash, I think there is more uritic injury in cases of the broad ligament fibroid, if you are repeating. Have you ever encountered uritic injury in the broad ligament fibroid while
No, sir.
enucleating?
Broad ligament, sir. I had a case where I had done that surgery very well, but most operatively the patient had a collection in the there's a broad ligament hematoma. There is a surgery. There is a hematoma in the area where I had operated. So the mistake which I did was I put a drain, but I removed it the very next day. So please
Okay.
remember that whenever you do a case of broad ligament fibroid, always put in a drain, and the drain should be in the area where you have done the dissection. कहीं पे drain का कोई फायदा नहीं है. So this is something.
Yes, yes. I have also encountered in one case of the broad ligament, pseudo broad ligament fibroid. Pseudo broad ligament fibroid is more prone
Pseudo
to,
only.
yes,
मेरा भी pseudo ही था sir.
yes, yes. And then I have recognized in the OT table also. Then we did the stenting and sutured the same sheeting. So, right. And any rectal injury?
नहीं sir, एक तो
You have
I had one
encountered?
rectal injury long time back, but I lost the patient. Not rectal, sigmoid.
Okay, I have one rectal injury in a pull-through operation, but fortunately, bowel preparation was good, so we repaired in the OT table only. So
But as I
patient was
told
doing
you,
well.
it's very, very, very important. So you have a tachycardia, always think in terms, an unexplained tachycardia, always when the patient has, think in
Yes,
terms
yes.
that sometimes the bowel injury could be a cause for it. That is why.
Okay, thank you, Subhash. And again, we will call you in the quota in the near future. Okay,
बिल्कुल sir, Raksha
bye.
madam, namaste. How are
Namaste,
you?
namaste, bye.
nice.
Thank you, Dr. Subhash. Yeah.
Thank you, ma'am. Thank you very much, ma'am. Thank you very much. And sorry for the Vande Bharat, because I was supposed to be Jan Shatabdi, but लेकिन it became Vande Bharat. काफी जल्दी जल्दी बात कर लिया because next case was ready. That is why, ma'am.
Chalo, chalo. Okay, bye.
Thank you, sir. Thank you very much. Minu, ma'am. Thank you, ma'am.
Okay.
Thank you, ma'am.
Thank you. Thank you. Very nice talk. Very nice. Good videos and everything. Thank you.
So I think, Raksha, we can wind up. And thank you,
Yes, yes.
KD sir. Thank you, KD sir, for taking out time for us. Dr. Meenu, thank you very much. Dr. Subhash, Dr. Desh. Mansi is always there working very hard. Dr. Kuldeep sir. Raksha, if you want to formally thank everyone, and then we can close this session.
Thank you, ma'am. I would like to thank our highly esteemed seniors for such a great pulse of wisdom and useful take-home messages. I would like to thank our media partners and pharma partners for the same. And last but not the least, I'm very thankful to all of you for giving me this opportunity to share this platform with so much highly eminent speakers. Thank you, ma'am. Thank you, Kuldeep sir. Thank you, Meenu ma'am. Thank you, Shita ma'am.
Thank you, Raksha.
Thank
You
you.
have done a great job. In the last moment, I told you that you will do this job tomorrow, today only.
Yeah.
Give me this opportunity, and in further sessions also I would like to join if madam would
Good.
allow me to do so. Thank you, ma'am.
Thank you, everyone. Thanks.
Good.